My name is Ros Taylor, and I'm very honoured to be the new National Director for Hospice Care. Thank you. Following in Heather's significant footsteps. And for those of you who are interested in hospice history and the life of Cicely Saunders and how she inspired us, I'm sure you know that she established hospices with three hopes, three pillars perhaps: research, care, and education. And sadly, the research pillar, I think, is a bit crumbly. And you also heard from Helen Bevan this morning in her inspiring presentation how one of the defining features of a social movement is curiosity. And curiosity should lead us to research. So I am delighted to be chairing what I know is going to be a scintillating session this afternoon in advance of the tea break, which I'm sure you're also looking forward to. And we have two speakers who are going to be entertaining and are at leading edges of research in palliative care. I'm going to introduce them both now, and then they're each going to speak for 15 to 20 minutes, and we will have questions. We've heard a lot about data this morning already, and there will be more. Research is only possible with good data, and I think there is an obligation for all of us to think more deeply about what we're going to hear this afternoon. Most of you are familiar with the reports from the Commission into Hospice Care, and there was a fantastic introduction to research in hospices in one of the Commission documents, and I urge you to read that, which is downloadable from the new Hospice UK website. So, first of all, we're going to hear from Dr Katherine Sleeman. Katherine is an academic at the Cicely Saunders Institute and a palliative clinician. I first met Katherine when she introduced me. I met her virtually when she introduced me to Twitter. I don't know whether to thank her for that. I also have heard Katherine lecture a few times, particularly around the LCP. She came to our hospice a couple of years ago when all of that was dissolving. But more recently, I've become her #1 fan, and I heard her at the Albert Hall, and some of you might have. So we've got a real celebrity here. Not many palliative doctors end up at the Albert Hall. And I urge you to watch her presentation on YouTube. Katherine's going to talk to us about the value of palliative research, and I will refer you to her recent editorial in the, I think it was the September or October edition of Palliative Medicine, or maybe even November. And then secondly, we're going to hear from Professor Joan Teno, who is a very experienced researcher in palliative care from the States. She has a deep interest in how we link quality, outcomes, and cost, and has done some pivotal research in care homes, and is challenging the government at the highest level to keep quality at the heart of funding formulae. I met Joan for the first time at breakfast this morning in the hotel, and I also discovered that she was deeply involved in the story of Oscar, the cat, who was able to diagnose when people were dying in a dementia care home. Now, I don't know if any of you remember the story of Oscar the cat, but I think we are very rubbish at prognosis, and perhaps we all need more hospice cats. Anyway, I'm now going to hand over to Katherine, so stay tuned and think about research.
Thank you very much, Ros, for that very kind introduction and for the invitation to speak. It's a great honour to be here, and particularly for me to share the stage with Joan Teno, who is a research hero of mine. So, we are all here to consider the value and importance of research in end-of-life care. Now, I'm just going to give a bit of a disclaimer. I'm not going to talk about my research. What I'm going to talk about is more of a hobby to me. And first of all, I'm going to tell you what I'm not going to talk about. So I am not going to talk about why research is required or important in hospice care, because as Ros mentioned, we've already covered this subject. Last year, the Hospice Commission published this report, Research in Palliative Care, which set out extremely clearly why it is necessary and essential for us working in hospices to carry out research. I'm not going to go through the 10 very convincing bullet points, but the bottom line is that medical research aims to improve care by working out what is effective and what is ineffective, and therefore it is important. So let's start with the knowledge that research is necessary to improve care. The question that I really want to think about and talk about over the next 15 minutes or so is, how much of the research that we do in palliative and end-of-life care actually ends up improving outcomes for patients, for families, and for society? How much of the research that we do is simply a waste of time, money down the drain? And I think it might be quite nice for me, before I speak any further, to find out what you think. So I would like to just ask people to give a show of hands up, who in this room thinks, and I know it's just a kind of average guess, that more than half of all research done in palliative care has an impact on patients, families, or society. Well, that's 3 out of, what, 500 or something? How many people think less than half of research that we do in palliative care has an impact? Practically everyone. That's pretty worrying. We'll find out whether or not that's accurate or potentially accurate. So in order to begin to answer this question about the impact of research that we do, I think we need to step back from palliative care, and I think we need to look at biomedical research more generally. Vast sums are invested in biomedical research every year. The annual global expenditure is around $240 billion. In 2009, Ian Chalmers and Paul Glasziou, neither of whom are palliative care doctors or researchers, published a seminal paper in The Lancet with the rather alarming conclusion that about 85% of that research expenditure is wasted, is money down the drain. They concluded that just 15% of the money we spend on biomedical research globally is actually useful to patients. It actually improves health. Medical research, it turns out, is quite extraordinarily wasteful. So where does this waste occur? Well, in order to answer that, we need to think about what the research process is. So we can think about research as a kind of pipeline, where we start with a question on the left-hand side, and we end up with an answer which we put into practice in order to improve outcomes for patients, families, and society. Ian Chalmers and Paul Glasziou, perhaps not surprising, found that research waste can and does occur at every single step of this pipeline. So it occurs because we ask the wrong questions, because we use the wrong methods to answer those questions, through inefficient regulation, or because the reports we write of our research are either incomplete or completely unusable in practice. So what about palliative care? What do we know about the research that we're doing in palliative and end-of-life care? Well, I think we're still a very new academic specialty, which is changing very rapidly. The number of research reports published in palliative and end-of-life care is increasing almost exponentially. There's been an explosion of research in our field over the past 10, 20 years. In line with that, research spending has also gone up over the past few years. But as we all know only too well, quality and quantity are not the same thing. So how much of this explosion of research is translated into improved outcomes for patients? What I'd like to do over the next 10 minutes or so is just go through each of those 5 steps, those areas where waste can occur, and try and put them into some kind of context for palliative care. I'm going to ask many more questions than the answers I give. Some of the questions I don't think even have answers, but I think these are the things that we should be thinking about, and hopefully we can discuss towards the end of the session. Okay, so first of all, With our research, are we even asking the right questions? Because if we ask a question which has actually already been answered, we just didn't bother to look, then that investment is wasted. If we ask a question that is of very little importance to patients or society, then that investment is wasted. So what do we know about the questions that we ask in palliative care research? Well, we do know a bit. So, for example, last year, the National Institute of Health published The Science of End of Life and Palliative Care. This was a review that looked at research, trends, and funding over a 13-year period. The review found, as we've just seen in the previous slide, that there was a threefold increase in palliative care research publications over the course of those 13 years. But the review found glaring gaps in important topic areas. For example, 2/3 of publications were in cancer, and very few concerned chronic multimorbidity, health economics, or education and training, arguably three of the most important questions for society. And I don't need to remind anyone in this room about the gaps in evidence which were highlighted by the Neuberger Review last year. Gaps not just around the LCP, but around education and training, again, around the biology of dying, people's experiences of care. The number of publications in palliative care may be increasing rapidly, but are we asking the most important questions? Do we need to refocus our questions in palliative care from research that can be done to the research that must be done? So, assuming we've asked the right question, what about our study design? Because, of course, however good our question is, if we use the wrong tools to try to answer it, we'll get an answer which is misleading or wrong, and that will not only lead to waste, but it may also lead to patient harm. Do we power our studies appropriately? Do we use the right statistical tests? Not surprisingly, perhaps, issues around research methodology are intrinsically related to the academic workforce. And in palliative care, there is a serious shortage of skilled researchers able to lead their own research and train others. So I'm going to put this in context with an example. This is the Royal Marsden Hospital in London. This is the United Kingdom. There are more professors of oncology at the Royal Marsden Hospital in London than there are professors of palliative care or palliative medicine in the whole of the United Kingdom. Where is our academic leadership going to come from? How can we possibly expect that explosion of palliative care publications to be rigorous and well-designed and meaningful if there hasn't also been a coincident expansion in our academic workforce? Regulation. I will speak very briefly about this. Anyone who's put in an ethics application, and I'm sure that several people in the room will have done that, will know that the regulation required to do research can be extremely burdensome. This is a real-life example of the amount of paperwork that can sometimes be required. Overly burdensome regulation causes waste, because it may not only delay important studies being done, but it may actually prevent them being done at all, which then causes patient harm. We know in palliative care many of our patients are frail and potentially vulnerable, and there has been historically, and worryingly continues to be, a sort of perception that it is unethical to involve our patients in palliative in research. In fact, there is good evidence now that it is desirable for patients with palliative care needs to have the opportunity to be involved in research if they want to. And in fact, I would go so far as to say that it is unethical to deny patients that opportunity. But convincing our research regulators and even our colleagues can be difficult. Okay, so how about research reporting? We've asked the right question, we've used the right methods, we've jumped through the regulatory hoops. This is the fourth leak in our pipeline. Globally, around half of all medical research is simply unpublished. It never sees the light of day. And of course, this causes waste because of unnecessary duplication, and it causes harm through biased reporting. It's very difficult to know how much research is unreported in palliative care. I don't have a good figure for that, but I bet that there are people in the room who know of research which is unreported and is likely never to be. What we do know is that of abstracts presented at the EAPC, so this was a study that looked at the 2005 abstracts, fewer than half eventually made it to a peer-reviewed publication. And that's the tip of the iceberg, because what we don't know is how many studies didn't ever even make it to the abstract stage. A bigger, and I think a more hidden problem, is not unreported research, but it's research which is half-reported. So if we think about it, when we start a research study looking at the top of the triangle, we start off with reams and reams of paper of participant-level data sets, SPSS data sets, audio records. And during the dissemination process, these reams and reams and reams of data are whittled down to maybe an 8-page study report, maybe an abstract, maybe a presentation. Of course, during this whittling down process, there will be selectivity and bias, which can potentially cause patient harm and cause waste. What we need to be thinking about is publishing all of our data, enabling all of our data to be freely available, even the stuff that didn't make it into the publication. In fact, especially that data. The question is how we manage to do that. And finally, I would like to mention the fifth and possibly the biggest leak in this pipeline, which is usability. So this is the process whereby a published report gets used by clinicians or policymakers to improve patient outcomes. I think usability is a really big problem in medical research. And one of the reasons is I think as healthcare professionals, we have this kind of concept that our research project is completed once we've published it. We almost see publication of data as the end result. We can wash our hands and forget about it all. But actually, that's really just the beginning. We should see publication as archiving of our data, quite a sort of convoluted and expensive way of archiving our results. What we then need to do is take that archived data and ensure that it's read, interpreted, and used by the clinicians and policymakers who are able to make a difference with it. And I'm really worried about this because I think actually the data we published is pretty much unusable. When we as academic write research projects up for publication, I think we have the journal editor in mind. I don't think we have the people who might actually use that data in mind when we do it. So I would like to ask you another question, the clinicians in the room perhaps. Can you think in the last 12 months, how many papers have you read in academic journals that actually caused you to change your practice? If the answer is 1 or 2, or if the answer is even, I'm not sure, I haven't thought of one yet, then I think we academics should be really worried about the usability of the data we publish. Publication is a means to an end. It is not the end in itself, and we need to get much more innovative about how we enable that message to get out. So I initially described this research process as a pipeline, a leaky one. But actually it's not a pipeline, of course, it's a loop. Because what we should be aiming for is a continuous cycle where the questions which are important to patients and carers feed into the academic setting where research is carried out, the results of which subsequently feed back into the clinical setting to be used to improve outcomes and to inform further questions. There are great examples where this continuous cycle works really well in practice. I believe that Joan is going to talk about a project that she works on with David Cassaray called about the Choice Network. But I think we all know of areas and examples where this cycle works really badly, if not at all. In fact, I think often there's almost a complete disconnection between the clinical setting and the academic setting. It's all of our responsibility, whether we're clinicians, managers, academics, all three, to close this gap. We need to ask questions and question answers and enable this cycle to work freely. The trouble is, how do we close this gap when we are so separate? Certainly geographically separate, but also, perhaps more worryingly, still quite ideologically separate. I mentioned earlier that the amount of research funding spent on palliative and end-of-life care has increased. What I fail to point out is that the absolute amount is still tiny. So in 2010, just £1.2 million was allocated to end-of-life cancer care in the UK. As a proportion of the total pot of money spent on cancer research, that was just 0.21%, which means for every £100 that was spent on cancer research, 21p was spent on research that looked at improving people's experiences and care at the end of life. In addition, that £1.2 million was allocated in a kind of piecemeal approach, such that the average award was only £25,000. The danger of this drib and drab approach to palliative care funding is that we will end up with a mass of studies that make little or no impact. And meanwhile, we will have to generate national policies out of thin air. So what is the value of research in end-of-life care? How much difference do we make for patients and families through our research? How much of the research that we do would be considered wasted according to those Lancet criteria? I don't think we know the answer to this, but I think we need to know the answer. I think we need to look at how efficiently that cycle from the clinical setting to the research and back to the clinical setting is working in our areas. We need to scrutinize the research we do and understand its inefficiencies in order to make the most difference for patients. So I would just like to leave you with a quote which I found this morning. It is terrifying to think how much research is needed to determine the truth of even the most unimportant fact. Thank you very much.
We're going to move straight on to Joan now. I forgot to mention that all presentations will be on the conference app. Do download it, perhaps when you're in a faster Wi-Fi setting. Yes, Joan, some very provocative questions from Katherine about the value of research, and it seems to me that if we are going to invest some more in research, we need to consider that pipeline so we do just the right thing. But more questions later.
Well, good afternoon. I'm almost ashamed to admit, but I'm a researcher. And I may be one of those people who's been wasting their money here. But I want to talk to you about some caveats and some challenges, because I think fundamentally it's very important that if we don't ask questions, we're going to end up doing things poorly. I'll just give you one of my favorite examples. In the 1960s, there was a surgeon who was the president of the Gastroenterological Association of America, who basically said we should be putting down a tube into the stomach with anybody who has a bleeding peptic ulcer and put in ice in a balloon. And he was charging for this procedure, okay? And this is a guy who was very powerful and had everybody using it until someone conducted a randomized controlled trial and found out it did nothing. So a lot of times we totally do something because that's what some expert said, and we don't openly question why that's being done. So I think it's really important that we in hospice and palliative medicine embrace the curiosity, embrace the willingness to ask questions. In my lifetime, I'm starting to get enough gray hairs here that I can tell you I went from, as an intern, watching people with an MI being kept in bed for 7 days. I actually prescribed Lanoxin in my lifetime, or Digitalis. Hardly ever use that drug now for atrial fib. All these things have come about by people doing research and asking questions. We used to treat urinary tract infections for 7 days. We now do a 3-day treatment for uncomplicated UTIs. All this was because someone was bold enough to ask the question, why do we do this? So I hope that you as an industry totally embrace the question, which is really about why do we do something? And the reason why is, I'm just going to show you a picture. This is my mom dying in 2008. Okay? She greatly benefited from someone developing a protocol for dealing with status seizures while dying. And because we had that protocol where someone helped us figure out what's the right dosing of drugs, she died very comfortably, to the point my then 18-year-old niece slept by her bedside. My dog, that's totally crazy, you know, usually is a Labrador bouncing off the wall, slept right underneath her bed. So I think it's really important that we embrace research, but I want to give you some caveats and challenges in doing so. So I asked sort of, why do I do something? The reason I do something is I firmly believe in person-centered care. And to believe in person-centered care, I really love this quotation. You have to be a commitment to being open, an openness to challenge, and the absolute priority of a patient's own views on what they need. This is really what our industry, what our practice is about, is taking care of dying patients and families. We need to have good research to guide that. Now, it's not going to be without challenge. And first of all, prepared to be challenged, because some of the research findings are going to say we can do better. 2, it's just not about utilization. It's not just about money. We need to value both quality and efficiencies. We love measuring utilization because it's easy to measure. But what we need to do is we need to have means of measuring the quality of care that is reliable, valid, and sound. I think one of the things we need to focus on is implementation and quality. We start with a good idea, and it works in this local environment because there's a champion there. There's this wonderful person who is out there advocating. But we have to focus on how we roll that idea out to the next set of interventions, to rolling it out nationally, so that we're accomplishing the goals of the original intervention. And then I want to talk to you about a challenge, and what I view as a beautiful sunrise, the value of observational data to answering questions. Okay, first of all, prepared to be challenged. It's a photograph I took up in Scotland. There's this lone tree that sits in this valley that's constantly hit by wind, and somehow it's managed to survive. So I've been associated with doing research that has made people very happy. This is one of my happy studies. It was published in JAMA, and what it shows is when people die with hospice services, they're more than two times likely to say that the care was excellent compared to dying in a nursing home, in an acute care hospital, or with home health services. Now, there's some work I've done which people don't like. Now, I need to tell you a little caveat here. I'm from the United States, and we're separated by a language called English. And when I say the word hospice, I am not talking about a freestanding hospice inpatient unit. I am talking about the Medicare hospice benefit. And with the Medicare hospice benefit, it is an insurance. So when someone meets the criteria of having a prognosis of 6 months, they opt out of traditional Medicare, and now that hospice acts as its insurer to provide all the care that's associated with that terminal illness. So with that, I'm going to talk to you about what happens when someone leaves that insurance and goes back to traditional Medicare, because that has been a marker of quality in the US. So I'm going to talk about what we call live discharges. That is someone deciding to leave Medicare hospice and go back into regular Medicare. So a live discharge can occur because a patient can choose to say, I no longer want hospice services. Their medical condition can improve because we have this rule that says you must have an expected prognosis of 6 months, or in the land where we have both for-profit and not-for-profit hospices, some hospices want to avoid expensive tests, hospitalizations, and they will discharge that patient, or they'll say, well, don't you really want to leave hospice services? And the concern is that the hospice may be avoiding a costly medical care. So just to give you some data, and I will be a self-professed data nerd. I love data. I love asking questions. I love trying to understand this. In 2010, we had about 1 million discharges from hospice. 18% of those discharges were people who were deciding, or the hospice decided for them, to take them off of Medicare hospice benefit and return them to Medicare. Now, 1/4 of those patients were hospitalized, and the majority of them were hospitalized within a day. That leads to the concern on whether there is a gaming of the system. Did someone do this to avoid an expensive hospitalization? So in the world of Medicare, this cost about $664 million just with that initial hospitalization among those people who are live discharged. So that starts raising concern. So we in the US spend about $15 billion, and we start looking at the care for these people who are hospitalized when they're live discharge. We're talking about $664 million. Now, sad to say, the majority of these people who are live discharges go on to die. Some come back onto hospice services, some don't. So it's a concern on whether this is a quality problem. So one thing, if you know anything about the United States, we are not one sort of nation. We are very distinct regions, and one of the concerns when you look at live discharges is there's a tremendous striking variation. And among that variation is, if you're in the deep south, you have about 40% of people who are discharged are live discharges. If you're in the upper Pacific Northwest or in Connecticut, the state next to where I live in Rhode Island, it's 12%. When you see striking variation like that, it is not because of what food people eat, it's not because of what eating they do. It's usually characteristics of the healthcare system that's accounting for that pattern and really reflecting the behaviors of providers rather than reflecting patient preferences. So the other concern is we have this very different type of system where we have for-profit providers. And the concern is when you compare the for-profit providers compared to the not-for-profit providers, there's a very different pattern of what we call problematic discharges. And I'm just going to focus on one row here, which is the rate of hospices with one or more problematic discharges. So we consider that, for example, if you have a pattern where you're discharged from the hospice, go to the hospital, and immediately come back into the hospice program, we call that a burdensome transition. And when we see a provider who is in the top 10th percentile of the rate of those transitions, we call that a problematic pattern of live discharges. Well, it turns out we identified 4 types of problematic live discharges, and it turns out the for-profit single providers without any organizational affiliation, about 39% of those providers met one or more of those problematic live discharges. If you're in a national chain, it was around 30%. But if you're in a not-for-profit hospice program, it's only about 10%. So there's a great difference in terms of what we see as the quality of care in terms of the rate of live discharges with the type of provider. So this is sort of the unpleasant thing, because this is questioning and saying, are we doing a good enough job? I think we need to look at this, because for me, that patient who goes from the acute care hospital, from hospice to the acute care hospital and back to hospice, I have to ask, are we doing right by that patient? Have we adequately talked to the patient about that hospitalization? Did we prevent those symptoms in the middle of the night? I think it's really important we ask these questions, because I'm a geriatrician, I'm board certified in palliative medicine geriatrics. I see day in, day out how hospitalizations in frail older people can be a dangerous place for them. So we concluded there's a substantial variation, there's an opportunity to improve, and this is a potential vulnerability of our Medicare hospice benefit. And it will hopefully be addressed by policy. So let's talk about implementation and money. So I just had the privilege of writing an editorial in JAMA 2 weeks ago, and it was based on a study by Overmeyer, which everybody loves the study. Decreased hospitalization among people who choose hospice matched to those people who didn't choose hospice. Big effect sizes. Decrease, 42% in hospice patients versus 65%. Decrease ICU and a savings of $9,000 per patient. Me being a little bit of a curmudgeon, I wrote an editorial and said, listen, we seem to be really focusing only on cost. Why aren't we talking about quality? Because we have a very convincing data on the quality of hospice care. And I sort of posed to the people, well, let's say you reduce severe pain by 50%, which is a huge effect size. And you reduced ICU care by 18%, but the cost of bringing the team together and providing additional services to maintain the patient at home costs $3,400 more per patient. Does that mean we should not try to attempt to reduce pain by 50%? So I think we need to start thinking more broadly that it's just not about utilization, but we need to think about quality. Now, ideally, we want to hit a home run. We want high quality, efficiency, safety, improved, survival. But I think we have to be prepared for some findings which are going to suggest that it costs a little bit more to provide high quality care. And, I think one of the things that Irene Higginson and the More Care Project did was to really think about how we implement and roll things out. That every time we take an intervention to another level, we need to think about, reflect on the intervention, and we need to focus not only on creating the research that says it works locally here, we need to think about how we disseminate that intervention throughout various stages. So when you go to national thing, you need to think about what kind of training do we need to provide to ensure that people are being true to the protocol, true to the intervention, true to the drug delivery system. So one of the reasons also I sort of wrote a more sort of challenging editorial about this paper was I'm very concerned about where we're going in the US healthcare system. We are now going from largely a fee-for-service system, which means if I want to get someone in the ICU, I have no problem. If I want to get someone's cabbage done, I have no problem. I just did it with my own father. I had him operated a day later after presenting with severe symptoms, and he has done fairly well. But we're now changing those incentives with bundling payment and creating this entity called Accountable Care Organization. So we're going from embracing paying for any procedure to now saying we're looking at both the quality and efficiency. My concern is none of our quality measures examines those people who are dying. Matter of fact, if you take a look at our standard quality metrics for people who are in the hospital, not one of the person-centered experience measures covers people who die, covers people who have dementia, covers anybody who goes to a nursing home. So how can we have a system of measuring the quality of care when you don't examine a vulnerable population? And that's who we care for. We care for a vulnerable population. So we need to demand of our healthcare system that we have actionable information on those people who are vulnerable. And just to give you an example, we lived through the 5 years of Sarah Palin and Death Panel. Now, if a Facebook posting can derail the entire end-of-life movement for 5 years, imagine if we had some data that really said there was harm. It would really set us back. So I think it's really important that as we do these new interventions, that we are very careful to ensure that the care is not about saving money, it's about respecting and supporting patient choice. So this is Sunrise, and this is actually where I live. I live 800 yards away from this, and to give you the full story, I was actually wading up to my knees with a dog swimming around me to take this picture so I could get it from the right angle. I think, one of the things that we can do, and we can all work together, is we can use observational data that we're collecting, data that's in our EMR, data based on our bereaved family member surveys, data based on chart reviews, to help us learn how to deliver high quality care. And that's part of what the goal of the Choice Hospice Network is that I've been working with Dave Casseret on creating. Our goal is to define safe and effective hospice care. And one of the things we've done from the beginning is we partnered with one of the leading software companies, and we thought ahead. We're only not about doing research, but how do we build a plan for dissemination going forward? So what we want to do is there's really an urgent need for defining evidence-based practice. We want to capture the EMR data to help us do that. We realize that you're not going to randomize this vulnerable population. So what we're trying to do is we're taking a database that combines EMR, that combines satisfaction surveys with the family evaluation of hospice care data, and we're asking questions. Right now we have 10 hospice, 126,000 patients with 5 years worth of data, and we're asking questions like, can we predict short-stay patients? Can we predict long-stay patients? Can we define functional trajectories of functional decline in patients on hospice services? Do patients die where they want to? Does a level of hospice care lead to bereaved family member satisfaction with the quality of care? All those are things that I think we can do. So like one study I did early in my career is we just looked at hospice use of volunteers in direct patient services and how it was related to satisfaction. If you did use more volunteers, you had about a 10-point bump up and people saying care was excellent. We all knew that. But until we published that data, we quantified it and helped make the argument why we need to keep a volunteer focus in the hospice industry. My goal is that we're really going to understand the context, processes of care, how the systems of care we create relate to very important patient outcomes. The hospice survey, which is now being implemented in the United States, is called the CAPS Hospice Survey as of January 1st. How it impacts on grief and bereavement. I think with this knowledge, we can now go back to providers, partner with providers, and say, here are the processes that result in less grief. Here are the processes that result in less symptoms of post-traumatic stress disorders. Here are the processes that improve bereaved family members' perceptions of the quality of care. So my goal is to really get back to where I began. I want us to be open to challenge. I want us to think about the absolute priority of a patient's own views on what they need and to create research that's going to achieve that goal. And if we achieve that, I'll be a very happy camper, or in this case, my chocolate lab Chino pulling my camera across the field and scratching up the back of it, but that's okay. Thank you very much for your attention.
Thank you, Joan and Katherine. What I've just learned in the last 40 minutes is that we're not spending enough on research, we're not doing enough research, and we're not doing the right research, and then we're not publishing what we do. So that's shocking gaps, and we all know that with more evidence, more compelling messages will ensure our future value. And I've been quite shocked by some of that data. One of my hopes in my new role is that we can look and support hospices to develop networks, research active networks, and find a way to support clusters of research, clusters of hospices to research together. Because otherwise we go back to Katherine's scenario where we have lots of little studies that don't actually add up to meaningful evidence. And we also have to concentrate on how to move real good evidence into practice. So on that point, I'd like to invite questions for either of our speakers. We've got about 10 minutes.
Hi, Gail Wilframson, St Luke's Hospice in Plymouth. We have a research hub, a palliative care end-of-life research hub, which is a collaboration between the academics at the local universities and the hospice staff. and anybody else who wants to join us in end of life. But what's happening in reality is the clinicians, they're really passionate and really want to do it, but it's the time commitment, because they don't have, there seems to be no posts where actually you can be a clinician and a researcher. And I just wondered if, you know, if we're really going to promote research, we really need to give people protected time to do it. I just wondered what your views were on that.
Katherine?
Well, yeah, I mean, I would say absolutely, we definitely do. I'm pleased and impressed that you have a research hub. I think that was one of the recommendations that came out of last year's Hospice Commission, and it's a brilliant idea to sort of join forces in that way. But yes, it comes back, I think, to the academic workforce. It's pitifully small in palliative care in this country. I'm not sure actually how it compares in the States. And I don't know what the answer is, but I see the problem because it's unsupportable at the moment.
And I think it's also back to the end point that a lot of clinicians, when they get to their most senior job, they've done their research and they don't continue because there's such a pressing commitment to clinical care.
Thank you, Robert. David Prowl from Hospice UK. Joan, we've been looking very closely at what happens in America over the last 10 years or so. There was a saying that what happens in America drifts over here. I don't know if that's just true of weather systems. But we are beginning to find for the first time the private sector and getting involved in winning contracts for healthcare, and seeing your research there and the concerns around, you know, the false incentives of wanting to make a profit, meaning you discharge people earlier than you would do from services otherwise. Do you have any particular words of advice for us as we're trying to navigate our way through conversations with our government about future funding structures for end-of-life care in this country?
Great. So don't do it.
Okay.
So no. So I really think it's important, and you know, I think it took us far too long to embrace a quality agenda. There, you know, although my research shows there are some for-profit hospices that are not doing a good job. There's also some for-profit hospices that are doing a great job. I think what's really important is that we must have transparency and accountability with a vulnerable population. And really what we need to ensure is that there is not only adequate payment, but also adequate measures that ensures that hospice programs are going to be striving to deliver high quality care. Unfortunately, we focus more on payment than we have done in terms of developing quality measures. My hope is we're going to have public reporting on the quality of hospice in about 2 years. And I'm hoping around that emphasis on reporting that will get programs to improve and enhance the care that they deliver to dying patients and their families.
Hello, Barbara Gale, Chief Executive, St Nicholas Hospice Care. I think there are a lot of trustees and leaders in this room, and I think if we really want to promote research in palliative care, we have to put our money where our mouth is, and perhaps rather than a new shop, perhaps we need research posts in palliative care. Our clinicians don't necessarily have the time. We've just appointed our first part-time researcher linked with our local academic institution and regional network. But perhaps more of us need to do that. Our trustees were good enough to take that money out of reserves to fund that for the first year, but perhaps that's what we need to do.
Thank you, Barbara.
It's Kerry Jackson here from St Gemma's Hospice in Leeds. We have appointed a full-time consultant in palliative medicine, research professor in palliative medicine, who does 2 days a week as a clinical consultant and 4 days operating as a research professor, and he's a joint appointment between us and the University of Leeds. Now, our board took the risk of funding that post for the first 5 years, and what's actually happened is that the professor has generated enough funding to pay for all of his 6 research sessions.
I did invite him here this afternoon.
But it was a very late invitation, I think, wasn't it? And it would have been great to have him here this afternoon talking about it, because he's attracted a 2 million NIHR research grant. So it's funding himself and lots more people besides research nurses. And I think there's a lot to learn from that, but it takes the hospice, it means the hospice takes a big risk at the start.
Thank you, but a great model.
I was interested in your point, Katherine, about the importance of the link between research and good policy. Politicians, though, don't always make policy on the basis of evidence or research. Ideology also has quite an important role to play. So I'd be interested in both of your views, really, on how we can make better use of research to challenge some of the myths and misconceptions and mistruths that sometimes guide the policy decisions that are made that will affect us.
Thanks. Yeah, I mean, I completely agree with you. It's sort of startling how few policy decisions appear to be based in any sort of evidence, even when there is evidence available. And I guess my sort of limited experiences is about little and often and reinforcing messages and presenting information in a way that politicians can be bothered to access. They probably won't download someone's paper in palliative medicine, but they might read a half-page policy briefing. And so that's the sort of thing that at the Cicely Saunders Institute we're trying to be much smarter about doing. Now, at the moment, of all our research, we might publish 50 papers and write 2 policy briefings. That is clearly not enough. We should be writing, all of our research should have implications at some level for policy or practice. We should be writing these things for all of our research and getting them out there. But I don't think we know exactly what is the right way, and I'd be really interested to know if anyone else has any views.
So I'm going to give you a very US perspective. When I release a research paper, I work very hard on preparing a press release that gets that information in the New York Times or the Washington Post. And what I usually have to do to accomplish that goal is to use a patient story to set up those research findings. So when I've had the opportunity to testify within the Senate Subcommittee of Aging, I often tell them a story. And then I tell them how often that story occurs and what happens. And it's really important that people learn by narratives. They don't learn by numbers. The numbers provide rates which help them understand how often something's occurring. But you first must capture their imagination about a story and what it means to a person's life.
Thank you. And I think as a sector, we're very good at stories, so we need to be able to translate those into compelling policy messages, I think. And we could look at how we can do that collectively. Any more questions? Maria, have you got a microphone?
I have now, yes. Thank you, Ros. Marie Cooper from Hospice UK. A question for Katherine, really, in relation to this whole thing about gatekeeping around ethics. And I think we've found a very creative way around that by using our research in the form of service development and surveys and things. I just think if we looked around the room as to the amount of development that's gone on in the hospice sector, take, for example, volunteering, the huge development in the role of volunteer, which is not coming under the paradigm of research, but it is new knowledge, and it is new, it's telling us something very fresh. But because the discipline and the gatekeeping around ethics, we have to be more creative in our ways. So I think there's a way of merging a hybrid kind of model of, you know, we can't be purists sometimes. We have to be very pragmatic. We have to be on the hoof and respond in the moment. And I think that is as useful, our learning, but we don't tend to attend to that in the same way as we look to the academic world. So there's something around how do we meet that new world of being realistic, in the moment, new knowledge, but having the credibility that academia has. Is there a way of actually finding a new model of sharing that kind of learning under a credible force?
Thank you. I mean, I guess I don't really have an answer to that. It sounds like an interesting model, and I would quite like to talk about it with you a bit more later. I don't know is the answer. I don't have the answer. Do you have an idea, Joan, how we could do that? I mean, it sounds like an interesting concept. What do you think?
I think it's about presenting data in different ways, and what we've learned about volunteering is very experiential. I don't know whether, Marie, you're talking about the narratives of volunteering or just the trends and what we're learning from data, but we're not even collecting the data on volunteering in a very systematic way, you're right. So I think some of that is about better data collection, and we've heard a lot today about clinical data collection, but you're right, as a sector, if we've got 100,000 volunteers, and we're going to hear more about volunteering later, we should be using that to much more influence and looking at in what research or service evaluation paradigm that could fit, and we should be publishing more. Okay, I think we're going to stop there. I would like to thank both of our speakers for provoking and challenging us and making us think. There will be more about the research agenda as the months go by. Thank you very much.